SICS, as you saw, that there are three areas we are focusing at this moment. Boramani is wound modulation for reducing astigmatism, and Rajiv Raut for this smart incision, where he is developing software which is going to be a big gift to the world of ophthalmology. And I'm focusing on reducing the size, and the why I went to this line, because first the phacosurgeons were always telling that the astigmatism is because of the small size of the incision. And so as I was forming the organization in 2005, I thought if we cannot reduce the size of the incision, we don't stand any chance of competing with the phacosurgeons. So in 2013, I demonstrated in Bombay the 3 millimeter SICS, and Haldipur has said that if you go anything smaller than that, then the phacosurgeon has to find a new place. So after 13 years, and then I demonstrated because in between there had been, as I'm going to show you, there are a lot of instrument modifications and other thing has happened, which helped me to come to this stage. And I'm going to share with you a pilot study. It is not, because continuously we are monitoring, and unless we get the proper thing scientifically, we want to have the big data. And as you know that 13% of all refractive error has got astigmatism. So astigmatism is something where every cataract surgeon wants to give a hematropia without any astigmatism. I choose frown incision because that is the best incision as far as the SICS is concerned. I have tried to do, because in my setup we do phaco and this thing, so I have taken a sample of 45 patients, and 15 we distributed between phaco 3 millimeter and 2 millimeter, and we have not taken any kind of exclusion criteria over there, any complicated cases, systemic illness and other things, and so the baseline is less than 2 cylinder, we have taken that. And the age group varied from 40 to 70. Now these are my modified instruments, and this has been possible because of these modifications. I've got a 2 millimeter Vectis, which is with a sharp edge and a hanging front, and the dialer also has been modified. Then I have this jet, what I have said, many a time the SICS surgeon will find that the endothelium is crowded with cortex and other things. So with this jet, I direct it in the lateral way and then wash out this. And directly, if you put into the endothelium, there will be a edema next day. So I don't direct it. I did in few cases. Then I thought this is contributing to edema. So I directed to the angles, so that the angle debris gets cleaned, and at the same time with the movement of the fluid on the top, the other cortical material gets cleaned. So there is a single jet cannula, there is a multiple jet cannula. Multiple jet cannula helps to clean up the wound debris. Now I have the marker is there, corneal, which I designed, that this 2 millimeter marker, and that helps. And the cannula, the visco cannula also, most of us are using the round cannula. So I thought that when you use a round cannula, when you go to the side port, descent separation happens. So what I did with this thing, artery forceps, I flattened it so that it becomes a square and it goes with the things. And I use Ambier side port. Most of you should use it, because if you go with a flat one, then you are really pushing through it and you are creating descent separations there. So Ambier is always recommended. And so this modification helped me. Now the steps of the surgery is that either you can do topical or peribulbar. Most of the time people say I'm 100% topical. I feel what right they have got to be 100% topical. It should depend on the situation. If the case is okay, then I will go topical. If the case is not proper, then why should I have my ego that I must do topical? There is no compulsion. And that anybody who talks like this 100%, he is just bullshitting you, and he is an egoistic person. He has no commitment to the patient. So I do peribulbar whenever I need, and if feel the patient is cooperating, then you go topical. The marking and then marking the steep axis, the best advantage SICS surgeons has got is we can do anywhere on the steep axis, which phaco surgeon will find it difficult to do, and they indirectly they may contribute to many astigmatism because of the oblique astigmatism, which they cannot correct, and so 2 millimeter. When I do that, I will just go into the video directly. Now I am focusing that if I 0.5 millimeter, how much astigmatism is going to happen. On 1 millimeter, if I go behind, because I am keeping the incision size same. So if I shift the from the limbus away, and what changes are happening, I am focusing on that. The rexis and other things I don't have to tell, everybody does that, and now I will see this. See when in the beginning when we are doing SICS, we are cutting the conjunctiva as if it has no importance. So any length and whatever we. And now we cannot, we should not do that, because we must cut as much as is necessary. We should not unnecessarily, make big incisions and then keep the conjunctiva hanging there. So 2 millimeter, I'm taking this incision about 1 millimeter behind the limbus, and what I do, the frown incision I take on the steep axis. I take in the autorefractometer my K reading and topo. They are almost similar, but manual I am not doing. Then in the topo, because I have the facility, so I am doing on the topo guided. And so once you take a frown incision, I give a 1.5 millimeter back cut on either end, so that the wound remains restricted to that area only, the 2 millimeter. And I took 2 side ports, because that helps me to clean the cortical material better. Many people do it with 1 port only, but I find it a little difficult. When difficult means it is not enjoyable for me. So as far as the lens delivery is concerned, either you can break it in the tunnel or you can divide in the SE. The choice is yours. But dividing in the AC for many people may not be that easy, because you must have a very steady hand to hold the vaccines with the left hand and then go on injecting viscoelastic with your right hand and break it. So that requires a little bit of mastery over your medium. So don't go for, and if you are going for 2 millimeter, first of all see what modifications are there, and if you have got the facility, reduce the size to 2 millimeter and see my instruments, but don't jump into 2 millimeter. 2 millimeter is not meant for the beginners, and so beginners should go with the standard incision and or smart incision, as Raut is promoting, but that will be more comfort zone. Because, and in each cases I am seeing the cornea. The first thing is that comes to our mind, that if you are reducing the size of the incision, the cornea can get buggered up. But that is why every case I am recording, because the cornea is absolutely, I will show you that the post-operative cornea is absolutely transparent in each cases. So it is only few cases also, but I am keeping record of every cases for my own learning. And the best advantage we have got in SIC is the pocket. Now because of the pocket, we can maneuver the lens without injecting it through the side port. So what I do, the pocketing, I go from my bar on the right or bar on the left, then create the pocket and then come to the center. Normally we go from the center to the periphery, but I go from the side, and because that gives me space, and then I can maintain the plane properly, and I see a completely space available to me. So I am putting a multifocal IOL also in this way, and the result is good. So you see that the cornea next day, first post-operative day, of course we have to have a longer study, and that I will come later. So The endothelial count fear is that we reduce, but in my experience, we are not reducing much of endothelium. And topography also, as you say, the astigmatism is reduced, but it needs much more study to, by the time the World Conference comes, I will be ready with much more data. I have kept the air bubble deliberately to show that it is the first day cornea. So this comparison is there, that the air bubble itself will speak for itself. So now this is when we compare the this thing, pre-operative and post-operative, then our experience is that it reduces. 3 millimeter, I have compared with 3 millimeter with 2 millimeter, and 2 millimeter definitely scores over the 3 millimeter astigmatism. And then we went for comparison with the phaco, and we find that the astigmatism almost comparable to phaco. At this moment, we can say it is better than phaco, but it is comparable to phaco, and it is a very small data, but we will come with much more study. So 2 millimeter MSICS has the potential to give astigmatic-free post-operative eyesight. So we are working on that direction. Thank you.